Greetings, my beautiful people. This is Holly. I am Queenship coming to you with another episode of Queenship Quarters podcast. And I am so excited today to have my sister Queen Anna King visiting with us today. We're going to have a discussion on perinatal mental health as a whole. We're going to talk about the Black birthing community. We're going to talk about cultural humility lens, all of that good stuff with this dynamic sister queen. Hi, Anna.
Hi, Miss Holly.
For the listeners and the viewers, I know Anna through my eldest jewel, Mercedes, and I also have had the pleasure of learning and under her tutelage here lately in the last few months at Maternal Mental Health. And she's just such a wealth of knowledge. So I'm so honored to have you on Queenship Quarters. Thank you so much and gratitude to you. And so can you just tell everyone who you are and a little bit about yourself and how you got into this world of mental health and wellness and maternal perinatal?
Happy to. Thank you for inviting me to be in this space. I've heard so much about it, and I know that it's a sacred space for you. So I feel honored that you asked me to join you.
Gratitude.
I've been playing around actually with this idea, like, who am I? We usually go straight to talking about our education, but we're so much more than that. And so
That's it.
I just think of myself first and foremost as I think a servant.
Yes.
I am here in service of humanity, human rights, and really just holding sacred spaces as you do with this particular medium, but holding sacred space for other people during times of transition, during times of vulnerability.
Yes.
And so I am a therapist by training, but I really do try to take a more expansive lens and understand that there's so much more that goes into healing than just sitting and talking about what's going on with you.
That's
We
right.
have to really take a holistic approach to understanding that we're humans living this really incredibly complex human experience.
Yes.
And there are so many different layers to that. And so I see myself as, just a healer and a space holder and a storyteller, and I empower other people to tell their stories. And I very much see that as directly tied to the work that I do in the birthing space. And so I kind of, in my training as a mental health professional, kind of tried on a lot of different, specialties, a lot of different modalities of working with people, found my way into the hospital setting. Always loved working in the postpartum units and in the neonatal intensive care unit, and then got an opportunity to work there full time and just felt at home. And so, I saw a lot of gaps in the system and just felt really challenged by the approach that our system takes to honoring the transition, the birth space, and felt called to do more work around that in the community. And here we are.
Here we are. Well, we're going to dive right into it because I know you're ready for whatever it is that's coming. So,
I hope
let's
I'm ready.
start off with some definitions for the listeners. So when people say mental health or mental wellness or mental disorders, if those are the right words, what would you define as mental health?
I like the invitation to play with the language. I just love to play with language and play with this idea that it's not one size fits all. So when we think about mental wellness, that's the kind of word that I'll anchor onto in this moment. We're really thinking about how we cope with those complexities of the human experience. How are we navigating that mentally, emotionally, spiritually? How do we approach and get through those circumstances? And when it comes to those really big impactful moments, or even the small ones, if it starts to get in the area that it's starting to impact our functioning and impact our ability to kind of actualize our fullest potential and really have a good quality of life, then it's, it gets into the area of maybe we need to start thinking about, you know, kind of identifying some additional areas of support. And so that's kind of how I conceptualize emotional wellness, mental health, is really just kind of looking at how are we coping with and navigating both the micro experiences, so the interpersonal, the ways that we relate to other people, the ways that we engage with the day-to-day life, and also, we can't not name the systemic impact. And so how are we understanding the person within the system? And so kind of tying into what I was mentioning earlier, we have to take a holistic understanding to know that it's not just what's happening to that person and who's sitting in front of you. They come with their ancestors. They come with the community they live in. They come with, so much more. They don't come as a blank canvas. And so,
we're going to get into that systemic type of stuff. I love it. I love it.
Yes.
Next definition, perinatal.
So I think there's been an evolution of kind of a consensus of understanding in terms of perinatal mental health in the most recent, probably 10 years or so. I think that folks have been looking at perinatal mental health for a little while, but there wasn't kind of a common definition, common understanding of like, and what are we talking about here? And so I think traditionally there's the idea that perinatal was really just those first weeks leading up to childbirth, and maybe the first week or two, a couple weeks after childbirth. But what we really look at now when we are addressing perinatal mental health is that full range of kind of immediate reproductive years. And so we're thinking about those who are thinking about getting pregnant. So people who are entering the fertility journey, and oftentimes that is accompanied by losses, pregnancy losses, folks who are experiencing infertility and are working with, various mediums and modalities to try and get pregnant. They are count kind of in that perinatal period. And then once someone conceives and they're carrying gestating that pregnancy, that time period counts. And then obviously childbirth. And then what we look at is up to a year, sometimes even 2 years after childbirth. And so when we talk about perinatal mental health, we're really looking at that wide range of people who are entering that transition to becoming parents. It also includes people who are introduce a child into their home via adoption, surrogacy, and that kind of wider range of understanding in terms of family.
And sort of linking on to what you just ended with, when we're talking about that wider range, I want to also sort of help our listeners understand inclusion and being mindful, and like you spoke of earlier, of our verbiage and language. So as we talk about perinatal and maternal mental health, can you sort of enlighten some of our listeners on some of the language that has sort of expanded or transitioned into some other words that we should be using to be mindful of everyone and including everyone?
Absolutely. I'm so appreciative of this invitation, because the more opportunities we have to really just educate the community on it, the better. So first of all, I also neglected to state that perinatal also includes partners and dads. And so traditionally we focus we focus so much on the person who's giving birth or the person who's carrying the baby, but we know now that fathers experience postpartum depression as well. We also know that women aren't the only people who conceive and give birth. And so we're thinking about the idea that, not the idea, but the reality that there are folks who enter the world and don't feel aligned with the gender and sex that they were assigned at birth. And so people who are gender expansive, people who are transgender, people who are non-binary, also conceive and give birth. And so we utilize gender neutral words and language so that we know that we are including and acknowledging that wider range of birthing experience. So we tend to say pregnant person, birthing person, postpartum
Gotcha.
person, and their support person and caregivers, other caregivers in the home, partners, so that we, are really honoring and being respectful that not everyone feels and identifies as a mother or a maternal.
So you spoke a little bit about not only the person that is actually going through the birthing process, but the partner. Can we talk a little bit about specifically first fathers or dads first, and then we could talk about
Mm-hmm.
other partners
Mm-hmm. Well, I
and how
mean,
that
it's
affects the family as a whole?
absolutely, and it's another kind of layered experience, layered kind of concept, but we know that fathers, about 10% of them will experience postpartum depression. And if the birthing person is experiencing mental health challenges in the perinatal period, those numbers go up to 25, 50, 60%.
Oh, wow.
And so it's not uncommon for folks to go to their obstetrician, their pediatrician, their midwife, whoever it is that's asking the questions about mental health, and no one ever acknowledges the father in that dynamic and in that
Yes.
family unit, and so they often go unaddressed, and
Wow.
it's really unfortunate that that's the case. We know that there are studies coming out that show that they also experience their own shifts in hormones in
Oh,
the
wow.
perinatal period. Oftentimes their testosterone levels drop after postpartum. They also experience the same release of oxytocin that we
Mhm.
tend to talk about a lot when it comes to chest feeding, breastfeeding, skin to skin. And
Mhm.
so when working with fathers and partners, I really strongly encourage that they do a lot of the same kind of bonding
Okay.
practices as we encourage for the person who's giving birth. And so I know my partner did it, my husband did skin to skin quite often,
Yes.
and that really helps to not only acknowledge in the incredible role that they play
Yes.
in terms of introducing a child into the home, but it helps them to regulate their own emotions and that hormone release.
Yes. So, as we're talking about this, let's define postpartum
Mhm.
and then tell us some of the symptoms that we may be experiencing or the person may be experiencing along the way that they may need to ask questions about.
So there's actually one opportunity here to offer a little bit of clarification. It's common for most people who are kind of outside of the realm of understanding perinatal mental health to just generalize it as saying postpartum. We all
Okay.
know what each other is saying, but
Okay.
it also really just refers to a time period. Postpartum
Gotcha.
is the time after giving
Gotcha.
birth. But so we try to encourage folks to use postpartum depression or postpartum
Postpartum
anxiety,
depression.
or
Okay.
to really say that this is what we're talking about. And
Okay.
so in terms
Yes.
of postpartum depression, it's also common for the general public to kind of have this understanding that oh, it's just the baby blues,
Baby,
but
I
really,
heard that during my time. Oh, it's
yep.
just baby blues.
Uh-huh. Yeah,
Hmm.
which is a thing. It's
Yeah.
not a diagnosis, though. It's a
Gotcha.
syndrome. So it's just that natural response to the super huge crash in hormones, the acute loss of sleep, and really just this huge role reversal and role change in that family unit for those first couple of weeks. And so
Okay.
anytime you go through a major transition, you move across, the
That's
state,
true.
or you do anything that's big, you're going to have a period of time where it's a little bit uncomfortable.
Okay.
That's kind of similar to what the baby blues are. It shouldn't last much longer than 2 weeks. It
Okay.
should typically resolve on its own. And I am mindful of my usage of the word should, because everybody's situation, again, is not the same. But in general, we notice that it resolves on its own within the first 2 weeks after birth.
Okay.
But it doesn't typically impact functioning. So it doesn't
Okay.
typically impact their ability to provide the basic care that they need to for themselves and their baby. Now it starts getting into the territory of postpartum depression when you're noticing that it's lingering, it's persistent, it's intense, the frequency of feeling sad, low mood, things like that. That's when you start to kind of start wondering if there's some postpartum depression. The other thing that is not often talked about is that anxiety anxiety is often a telltale sign of postpartum depression, as well as irritability and anger, which is also one of the telltale signs that a father might be experiencing a version of postpartum depression. And so this is how it starts to get a little bit different than the traditional major depressive disorder that clinicians are used to working with. In the perinatal period, it can show up very differently, and be characterized by a little bit more anxious features.
So when you say it can show itself through irritability and anger, is that like a consistent thing we would see? You would see that like more often, you're just flying off the handle? Or is it just how, I guess I'm asking, because things can happen during times you just might be angry. So you know how people are quick to want to label. So should it be, how can we sort of say, okay, we might need to go and talk to somebody?
What I really like to recommend, because the general public and the clients that I work with, they're not going to come in and say, I have postpartum depression.
Right.
I'm feeling irritable.
Right.
What you instead start to notice is the language they're using. And so if you notice that regularly, they're like, I just don't know why. I don't have the patience. I don't have the tolerance for when my baby cries. I feel like such a bad parent. I feel like such a bad mom. I just can't handle it. I can't tolerate. Anytime the baby cries, it makes me so anxious. I don't know what they need. I can't figure it out. I feel like I'm failing. So you start to hear that language, and then you start to recognize like, okay, this person might really be struggling.
Yeah. So on TV, social media, we always see postpartum depression on that extreme. That we always see that the person or the mother, as they show on TV, is ready to kill the baby. It is a spectrum, right? It's not just one postpartum depression and then you automatically in that end of it.
Nope. I would love to clear this up.
Okay, thank you.
I will say this in one sentence. Postpartum depression, no, 2 sentences. Postpartum depression is not the same thing as postpartum psychosis. They are 2 separate disorders, 2 separate conditions. Second sentence, postpartum depression does not lead to postpartum psychosis. They are 2 separate conditions.
Okay, listeners, y'all hearing that? Viewers, y'all hearing that? We just throw that in the same pot.
The media has perpetuated this misinformation and misconception over and over and over again, and it is exhausting because not only does it misinform the public on what the real is, it perpetuates the stigma around parents getting the help that they need. So someone who is struggling with postpartum depression may think that means they're going to hurt their baby. And because of the way that the media and movies kind of show and portray it as related to one another, they are less likely to get the help that they need in a timely manner.
Right. So postpartum psychosis is that extreme I'm asking you about, right? No.
So it sounds like you're still using the spectrum. It's not a spectrum because they're not the same condition, right?
Okay, I'm
2 separate.
Okay.
It is. So this is the shift in language I'll invite. Is postpartum psychosis is an emergency. It is a crisis circumstance. There is a risk of harm to the child or to that birthing person. It's not the other end of the spectrum of postpartum depression.
Gotcha. Okay. I got it.
So it is an emergency, but it only happens, it's very rare. It only happens in 1 or 2 in every 1 to 2,000 births.
Really?
It's very rare. So the times that you see it in the news is like that 1 in 1,000 time that it happened.
Wow.
But people like to, there's the way that the media likes to hop onto and latch onto the stuff that's going to get a lot of clicks and, really find entertainment in other people's tragedy. And so this has been the consequence, that now we have this general understanding that's misinformed
Yes.
that they are the same thing. Now, that doesn't mean that someone with depression can't later develop some forms of delusion and psychosis, but it often presents very different than postpartum psychosis. Postpartum psychosis is often tied to undiagnosed bipolar disorder. Now, I know this isn't the kind of platform to really go into those nitty-gritty details, but it is another kind of vote in the pot of early intervention, prevention, education, really looking at what is this person's history? Do they have history of anything at all?
Right.
And how are we really supporting and keeping an eye on that so that potentially when they give birth, it's not going to trigger something like a postpartum psychosis episode. Postpartum psychosis typically occurs in the first month after birth, and it's typically really related to that sleep deprivation. So whenever parents are, intensely sleep deprived, if they do have kind of that underlying bipolar disorder, that can trigger a psychotic episode.
So can I ask a question about if they have some history of some kind of mental health disorder or something like that, how is that during the pregnancy time as far as treatment? Are they supposed to stay on the treatment prior to? Yeah, I'm interested.
Yes. So this is another misconception. We're getting into all of them today. I'm so excited. I hope everybody listens to this. All those doctors. Oops. And so, so in terms of treatment, if someone is already being cared for, receiving care for their mental health, perhaps they're on medication, perhaps they're getting psychotherapy, perhaps they're, getting any number of treatments that are helping them manage their mental health. The first thing that often doctors do is they also have this misconception that you can't take medication during pregnancy, which is not the truth. That's a myth. There are a lot of medications that have been well studied and are proven. They are, I hesitate to use the word proven, but have been found to be safe during the pregnancy period and during lactation. And so I highly recommend people who have withstanding mental health concerns and are thinking about getting pregnant or have gotten pregnant to get connected to a reproductive psychiatrist, because they're going to know what medications are the safest, how to tweak their regimen. It doesn't always mean that if there's a medication that maybe had a slight risk in the perinatal period that they're going to take them off of it. If anything, it's a risk-benefit analysis. So you're weighing the risks of exposure to the mental illness, which we know chronic stress crosses the placenta. There's increased risk of substance use, intimate partner violence, exposure to that versus exposure to the medicine. Which one is the best option and choice for that person? And so I always recommend that if folks have mental health concerns and they're thinking about getting pregnant, to stay connected with their provider and do not stop their medication, because oftentimes that's when they will have an acute increase of their symptoms, and people are confused why. And so I think I'll stop there. Because I could just keep going.
Right. No, I'm loving it, and I know it's very educational for our viewers and listeners. And so, what do we do? Let's get to the systemic parts. And you had spoken a little bit earlier, briefly, on the gaps that you have found. What are some of the gaps systemically that you've noticed? And then we'll get into the whole, as we just got out of our conference, of the whole person care type of holistic approach.
How long we got today, Miss Sally?
we still got a good 30 minutes to go. So come on. So what are some of the gaps you've noticed?
Paid family leave.
Yes.
Parents are forced to return back to work way too soon.
Yes.
In the birthing space, there is an abundance of implicit bias and harm done to birthing people. In particular, Black bodies, brown bodies, queer, trans bodies.
Yes, we're going to get into that too.
There is a kind of underpinning of context within the reproductive care system in America that
Mm-hmm.
is rooted in racism.
Okay.
And so that has influenced a lot of the care that is provided in the hospital setting, in particular, the hospital setting, for folks that either prevents them from getting the care that they need, dismisses the needs that they have.
Yes.
There have been studies that show that Black and Brown birthing people get medications to manage their postpartum pain 3 times less than white-bodied birthing people.
Wow.
Black and Brown individuals get and experience postpartum depression and perinatal mood and anxiety disorders 2 to 3 times more than white-bodied individuals. And those numbers have gone up to about 60-70% in Los Angeles County, where we work.
Wow.
And so there's the public health kind of issue that a lot of funders and nonprofits and activists have been working around in terms of maternal and infant mortality.
Mm-hmm.
And so we know that Black, Brown, Indigenous bodies are dying 3 and 4 times more. And Black babies die 2 to 3 times more in that first year than white-bodied babies. And so the gap is vast.
Yes.
And we know that even for Black bodies, in particular, Black African-American identified birthing people, just the day-to-day living experience and microaggressions and historical ancestral context of intergenerational trauma that was passed down from their enslaved ancestors has played a role in the chronic stress that their bodies experience. And so when they enter the perinatal period and that kind of context of racism that they continually, ongoingly experience, we know that creates this environment, this stressful environment in their body for the baby. And so that is tied to some of these poor postpartum health complications, such as premature birth, low birth weight for the baby, increased rates of hemorrhaging in the postpartum period. And so it's pretty evident. There's research to support it, but there's still some people coming around to this reality today.
Yes. So are you seeing, and I'm going to have you back with some other sisters that I just met, but in the Black birthing community, because I want to talk about, and you can speak briefly on what you know too, on some of the rights that we have as Black and Brown people when we are going through hospitals and doctor visits. What are we okay or should be okay to say about ourselves and our bodies? What are you finding and hearing in the trainings? And we're going to talk about some of the trainings that you do in the Black birthing community. What's okay for us to say about our bodies and when we're going through this time?
So self-advocacy and maintaining autonomy. That's kind of what you're talking about.
Yes.
So really, oh wow.
Because we're so used to just going off of what they tell us, and we might not be feeling that way, or we might not want to get a C-section. But we just say, okay. But I think I want our listeners and our viewers to know that that's okay, though.
It's okay and it's necessary. Unfortunately, we are going to have to advocate for ourselves because at this point, nobody else really is.
Yes.
I would say that number one, what has been shown to mitigate some of these risk factors for Black birthing people is to have a doula. Doulas are a complete wealth of knowledge. Birth workers, some folks don't identify with the word doula. So doulas and birth workers have a complete wealth of knowledge about the birthing space, the birthing process, how to support you in that, and how to be a voice for you in that space where you are at times feeling so vulnerable. They, depending on COVID protocols, can often come with you to some of your doctor's appointments and really help build that relationship with your physician, obstetrician, or your midwife. because unfortunately, even in some midwifery spaces, it's not 100% safe. I mean, nowhere it's 100% safe, but there are times that you'll have to advocate for yourself.
Okay.
And so it's absolutely okay to advocate for yourself.
Yes.
If you feel at any point that someone's touching you, they didn't ask you permission, and you feel uncomfortable, then you say, I do not feel comfortable with this touch.
Yes.
And that's it. Or
Yes.
they ask you if they can do something. No is a complete sentence. And so, and
No,
particularly,
period.
no. And so you have rights around, asking for time even to think about a decision.
Okay.
If it's not emergent,
Yeah.
of course, if it's an emergent situation, oftentimes there are things that they do, they claim they have to do. And so that's where it gets a little sticky. But I will say that there are a lot of opportunities to advocate for yourself, absolutely getting educated in advance what those are, and really speaking up whenever you feel like there's something being done that you really are not feeling okay with. And you have a right to ask for them to explain it to you again. You have a right to ask for them to give you the risks and the benefits, because sometimes they'll just come and say, we're going to do this. And then that's it. And then you say, okay, what are the risks and benefits? What's your experience with doing this procedure? What are your rates of? And so that's another question that I encourage my clients to ask their when they're interviewing obstetricians or midwives is, what is your rate of cesarean sections?
Yeah.
And that'll tell you a lot about their kind of decision making in the birthing space. And so, you don't ever work with someone if you have, so this is another gap in the system, is if you have the availability and the flexibility to choose who you work with, these are some questions to ask. But there are some people who just don't. There are some people whose medical coverage only covers a certain kind of a certain group of doctors, and only covers them through pregnancy. So we think about our undocumented and immigrant families and their limited access to care. And so we could be here talking all day, but absolutely advocacy is imperative.
Wow. That is so, because like you said, it's like, that's a good point when you said, what is your experience in this procedure? And when you said that, it's sort of just, even in just on a regular doctor's visit, when they diagnose something, that's really the furthest thing that you think of, because you automatically are saying, okay, this is the doctor. That's what they're saying. But my doctor, he laughs at me all the time because he'll say stuff to me. I was like, no, I don't want to do that. And he's like, well, but I'm saying you have
What are my options? You just ask, what are my options? Is this the only option?
And is this the only option? He's been with me through all my children. He's like, you just always so difficult, Holly. I said, I'm not being difficult. I just don't. Yeah. I just don't want to, and I don't think I need that. Huh?
That stereotype, though, that's the other thing, is pushing back on those stereotypes they try to put on us, on our Black bodies, that we're being difficult, or we're being complicated, or we're being angry. Like, no, I'm just trying to make sure that you're doing right by me and my body.
Exactly. That's it. And that's true. He does it, and I tell him all the time, and he accepts it because he knows that he can't make me do nothing. But I just find that very interesting. Like you said, Black and brown, how we really have we got to get to the point where we can't advocate for ourselves and be okay with that and have that backing. So in some of your trainings, you've done a couple of, I think you've done a couple of conferences or workshops with the Black birthing community. What were you offering in those trainings?
Yeah, really, it's just another kind of conversation about this kind of framework that we've created around even perinatal mental health, that doesn't always really apply in the Black community. That because of this larger context that we're working with in terms of the medical system, providers really of any sort, there's not a lot of trust there. And also, culturally, we don't really respond to this individualistic approach to healing. We respond more to, community healing and connecting with people who look and feel like us, that we feel safe and comfortable with. And so number one is peer support. And so
Okay.
oftentimes it's about connecting other Black pregnant people with each other so that they
Yes.
can really be a witness to one another, really connecting with elders in the community so that they
Yes.
can hold that space of wisdom and pass down
Yes.
that knowledge. Thinking about, other modalities in terms of movement and expressive arts as
Yes.
a way for Black bodies to access that full
Yes.
range of emotional expression. Because as we were just talking about, these stereotypes really often create spaces where we don't feel comfortable expressing ourselves in terms of
That's
how we
right.
really truly feel, which is often, there's a lot in there. And
Yes.
so creating spaces for that full range of expression and emotional expression to happen, like our ancestors
That's
did
right.
in community through song and dance and art,
Yes.
can go often much further than sitting and doing talk therapy.
Yes. And so coming out of our conference, we just had day one full of expressive therapy, which I thoroughly enjoyed. Let's talk a little bit about when you spoke about you're a storyteller. How is storytelling and what you know of the expressive arts very helpful and therapeutic and when it comes to health and wellness, mental wellness?
It's so powerful.
It is.
There's so many different entry points, and it's so unique to that individual. I think what often happens is there are multiple processes happening. So there's the person telling the story, and the
Okay.
way that, you'll notice that someone telling a story now versus how they tell that same story in 10 years
Yes.
changes a lot.
Yes.
It's often influenced by the way that they're making sense of things, the experiences they've had, and really, speaking to this integrated understanding of what it means to live in their body,
Hmm.
um, and on all the levels, mentally, spiritually,
That's
emotionally,
it.
physically, but like in a non-separatist way, like it's
Okay.
all one thing.
That's
And
right.
so you hear all of those layers come through when someone's telling their story. So that's the one path. The other
Okay.
thing is the person who's witnessing that
Yes.
story is also being impacted,
That's right.
right? So they're hearing, they're witnessing, they're learning, they're integrating, they're assimilating, they're,
That's right.
processing what's being
Yes.
spoken, and it changes their worldview.
Yes.
Then there's the other folks who come across that story who may feel seen, who may feel reflected and mirrored in
Yes.
what's being shared, to help
That's right.
them make sense of their own story, to help them feel normalized and comforted in the fact that they're not alone,
Yes.
to help them not feel like they're isolated in their experience. Though unique, there are often common threads that remind us of our interconnectivity. And
Yes.
so I think that that's just one way of describing the power of storytelling.
I'm telling you, storytelling, it's just like you said, it's a connection. It's
Mhm.
like you said, a witnessing. It's a um coming together on an energy that, okay, I'm not alone. Um, because a lot of times when we're going through these traumas in our lives and through our journey, we feel a lot of times that we're by ourselves. And so I really truly think, and of course, faith based, they grow up saying, your testimony. Your
Mhm.
testimony will help
Yep.
somebody else.
Yep.
So that's how I look at storytelling, is that it draws other people in. You can lean into what you've been feeling, and it's just a powerful, powerful tool. And
Mhm.
I'm so excited to hear and see in this community where they're using this art. I just say the arts
It's
as
art.
a
Mhm.
way of health and wellness and healing. And so, me personally, it's a movement in music. I think culturally, ancestrally, music is our healing tool for us. And so,
Mhm.
do you see more of the expressive therapy coming to play in healing through this community,
It
or
really
would you?
depends on the it
Okay,
depends on the therapist.
okay,
But what I will say, like an example, and I had already I had already been pushing back on this. I'll say I'm trained in EMDR, which is eye movement desensitization and reprocessing, and it's a therapy for trauma.
Okay.
They say that this person, Francine Shapiro, came up with this therapy where you do bilateral stimulation on the right and left side of your body. That she discovered it through a walk in the park. And she noticed that this distressing thought that she had decreased as she was, taking these bilateral movements of her feet. And I was thinking about that, like, that sounds like something we've already been doing. But okay, so I took the training and I started to feel that more and more, like this feels. And so I think that's a little bit of more of the movement that's happening, is understanding that a lot of these therapy modalities that have been repackaged and sold to us are just a reflection of things that we've been doing for centuries. But just calling it a different technical name. And so when we think about, so you were saying that ancestrally you feel drawn to music and dancing, we think about even like drumming.
Yes.
Look at that bilateral stimulation.
Yes. Okay.
Rocking.
Yep.
Rocking.
Yep.
So this is the kind of education that I bring into the therapeutic space, is telling people that this wisdom already lives in their body. There's nothing that I'm going to be able to come and tell them that they don't already know and hold in their body. But instead, what I'm doing is helping them remember, realize, actualize, tap into the healing capacity that they already hold, that their ancestors held, that passed down from there. So I mean, I don't know if I can really speak for the whole community. I think there are more people coming around to this idea of decolonizing mental health practice and thinking about how, in the West, these white, elitist, cisgender men went out and studied what people were doing and then, put a name on it and sold it, as this brand new idea. And really just kind of understanding that our communities already have the tools that they need to heal. We need to think about how to remove the barriers for them to access their fullest capacity. So I can only really speak to myself and, some of the people that are in my community in terms of what we're doing to shift the therapeutic space and the work that we do in helping people access those expressive arts. But it can look so many different ways, and you don't have to necessarily have extensive training to be able to invite that into the space. Like helping someone tell their story is so profound, and you really don't have to have a lot of training to be able to do that.
And something, I figured that out. Well, stuff I've been doing for like 20 years. When I was at the conference, I told the presenter, I was like, I've been doing this already with women and youth in my community this whole time. And now I have a name. I just was calling it my gift and my purpose. And so some of the experiences and spaces that I provide has storytelling, has movement and music, has spoken word. And so all of those things, it was just like, that's why I was so excited on day one. Both days were great, but day one, I was just in my element. And I was like, yes, this is what this is called. So that's I really hope that people are opening up more to sort of have this holistic viewpoint and this lens of healing in that. I wanted to sort of just backtrack a little bit when we were talking about dealing with postpartum depression. What can we as supporting family members, the village, what can we do to help support during this time?
So I love that you use the word village. The African proverb, it takes a village to raise a child.
Yes, it does.
Because it really, truly does. And another gap in our system is that people are forced to raise their children in isolation. And this is not the way we were meant to do this.
Yes.
Just had to add that in there.
Yes, that's right.
I will say that because a lot of the stigma around, what is quote unquote a good parent, a good mom, or a bad mom, keeps people from asking for help. And so what
Okay.
I often encourage support people is to just do the thing. Like, don't ask them what they need because they don't often know what they need. Just
Yes.
wash the dishes, wash the
True.
clothes, bring the food, hold the baby if they feel
Yes.
comfortable with that.
Yes.
Wash the pump parts,
Mm-hmm.
go to the grocery. Just do it. Just
Yes.
do
Just
it.
do it.
Just do it. Maybe even setting up a meal train with people that someone's having a baby, they got to eat and they're not going to
Mm-hmm.
have a lot of time to cook or even
Mm-hmm.
the mental capacity to put together a meal.
Mm-hmm.
So put together a meal train, take turns. I got all
That's
the
awesome.
next Mondays for this month. I got all the Tuesdays. I got all the Wednesdays. Just do it, because they're not going to often be able to tell you fully what they need,
Yes.
nor feel super comfortable doing that. I also like to encourage, especially those folks that are in the closer inner circle,
Mm-hmm.
sleep is really important. Sleep
Oh,
is so
yes.
important. It's so important. And
Mm-hmm.
we discount how important it is to help new parents get rest.
Yes.
We kind of lean into this idea that when you have a newborn, you just don't sleep, as if we're supposed to be okay with that.
Right.
But historically, sleep deprivation was used as a torture,
It
like
sure
to
was.
torture people. And
Yes.
so it's really challenging. And if someone, that someone struggles with their mental health in general, they're going to need that support. And so, if you can, take a night shift or take half a night shift, maybe you
Yes.
and somebody else will, I'll take the 8 to midnight and then, or 8 to 1, and then you take the 1 to 5,
Mm-hmm.
so that person can have some good solid chunks of sleep.
Yes.
That can make a world of difference.
Mm-hmm.
Inviting them out for a walk.
Yes.
Just show up. Well, I don't know, sometimes not show up, but just say like, hey, we're going to go on a walk on this day and this time, be
Right.
ready.
Right.
And get them out of the house, get them moving, because then it gets both them and the baby out of the house. They can get some fresh air, they can get
True.
some exercise, some movement, and all of that can really go a long, long way in helping them not feel so alone and isolated.
Yeah.
Oftentimes I find that whenever that immediate support person, caregiver, partner, husband, whoever goes back to work, they take a dip, because all of a
Yes.
sudden they're all alone and they have to do
Yes.
it all on their own, and they feel like there's no one there to help them. And so I
Yes.
encourage folks to really just step in, and don't do it just in those first couple of weeks after birth.
Yeah. And then you
Continue
gone.
that.
Yes.
Continue
Yes.
to do that for 4 months, 5 months. We
Yes.
were just doing a project the other day and thinking about how often we should screen in the first year. We know that the rates of suicide actually go up at the later in the year you go. And so
Okay.
like 6, 7, 8, 9 months, people need extra support then too. And
Yes.
so oftentimes, even for some folks, postpartum depression doesn't even show itself or even kind of surface until 6 months
Okay.
postpartum.
Okay.
So I would say, just really stay in touch, check in on them, let them know that you are someone that they can call up at the 3 a.m. and say, I have my phone on. If you
Mm-hmm.
need to talk to someone, if you're
Mm-hmm.
feeling lonely, if you need to connect, I will turn the phone volume on.
Mm-hmm.
You can call me.
That's right.
And then they know, even if they don't call you, they know that there's someone that is going to be available if they need to.
Yes.
So it's really about just kind of anticipating that need and just taking care of it. Don't wait for them to ask you, because it's not likely that they
It's
will.
not likely. And it's so funny, everything that you said, I don't it could be from, I had this old school Southern mother. I grew up in the South. I don't know why it sort of has faded out, but it really was that village. For all of my siblings and myself, when we had our children, my mom came and stayed for 6 weeks, helped with all of those things. Then after she left, then it was always, Miss Mary next door, or somebody at the, down the street, or whoever was in our village. Like you said, they rotated and they did those things for you. You always didn't have to worry about cooking. And because a lot of times people, not only with this infant, they have other children already. So they
Yes.
come in and they make dinner, so the person wouldn't have to make dinner. So all of that, like you said, is already and has already down generations been in our culture. And it's very sad that we have strayed away from it. We don't know our neighbors anymore. We move so much now that our children don't even have the opportunity to develop those lifelong relations. I still have relationships with childhood friends because we all grew up in the same neighborhood, and that's so sad now that they don't have that opportunity to sort of nurture those villages like we should. So
And we're
everything
seeing
you
the
mentioned was
consequences of that.
yes, in it. So before we wrap up, I do want to hit on because what we do at our agency is work with providers in trainings. What types of trainings are out for providers and workers? Because you're on two sides of the you're a provider too, you're a therapist, and you work with providers and give training. So what are some key trainings that we provide and that that are out there for people who work in the community, in the industry?
Yeah. So I really recommend, I'll just first say that the trainings that we have are really, we try to make them accessible to anyone who works with the perinatal community. So you don't have to be a therapist or a doctor, an MD or a PhD or anything like that to benefit from this information. Really, we know that even from the person who the pregnant person sees the moment they walk in the door has to have some idea of how to really create a space that person's going to feel comfortable speaking up if they're struggling. Right. And so even from the first person that they have contact with can benefit from this knowledge and understanding, especially when it comes to providing affirmative care. So for queer and gender diverse people who are coming into an office and everything says mom, mother, hey, mama, that's not going to necessarily be a space that they're going to feel welcome. And so in terms of trainings we have available, we do a series of self-paced online trainings that are available anytime. We have a whole suite. They are all 2 hours each, with the exception of our bundle course, which is kind of like Perinatal Mental Health 101. And it's technically like a 12-hour course with the reading material attached to it. And so our 2-hour courses are kind of touching on various advanced topics. So we have one on perinatal loss. We have one on intersectionality in perinatal mental health. We have one on suicide and perinatal mental health. We have one that's geared for pediatricians, obstetricians. We have one that's just on psychopharmacology or medications, which again, it says psychopharmacology and perinatal mental health for physicians. But if you are working with folks and you have any understanding or have to have any basic understanding of the medications, it's still good information to know. It's good for me to know in my practice. And so we have that whole suite of trainings. And then our organization also offers live trainings. So we can tailor them to the need. We have organizations that come to us and say, we know a lot about, this thing, but we really want you to focus on how this impacts the early childhood. So 0 to 5. So how does perinatal mental health impact the mental health of infants up through preschool age? And so we'll change the training around to really center understanding infant and child mental health, but through the lens of understanding the parent's mental health and how that impacts and ACEs, so adverse childhood experiences. And so we have a lot of flexibility there. We also have a training faculty that's available to us that has a range of expertise. We have one person who has an expertise in pregnancy denial and postpartum psychosis, and she's a forensic psychologist. And so she serves as she testifies in court for cases of postpartum psychosis in order to advocate for that person to not get the traditional kind of decision from the judge that it would otherwise, because people are so misinformed. So anyway, we tailor the training to the need. We really, pride ourselves in that. We also offer conferences, which you just got to be a part of, one of the big ones that we do. We do them about every 18 months. And so we'll host a 2-day conference. We pick a theme. This theme was whole person perinatal mental health. So really taking a holistic
Yes.
understanding of how to address perinatal mental health. Our last big conference like this was the Sex and Perinatal Mental Health Conference, where we talked about, how to support couples in the postpartum
Okay.
period, how to understand, birthing people who experience a 4th-degree tear during birth, how
Oh,
that
okay.
impacts their sexual
Mm-hmm.
functioning and the whole range. And so you can always be on the lookout for those. We just recently started hosting a law and ethics conference every other
Yes.
year, because clinicians typically have to have 6 legal and ethical continuing education units. And so we'll plan to do that again in 2023. What else? We've got
And so,
lots. We
so,
do a
so,
webinar
so our
series.
organization does give out CEs, and we do offer CEs, right?
We do. For all of those online trainings, we offer continuing education, the self-paced ones, and it's also an option to add on the continuing education if we do a live training.
Good. And then we have webinars, you
And then the
said.
webinar series, yes. So the webinar series completely free. We pick a theme for the year, and then we usually have 3 or 4 webinars for that year, and we make it completely free because it's our way of giving free education to the community. And so we invite experts to come in and talk about different topics aligned with our conference this year. Our webinar series is talking about complementary and alternative treatments to perinatal mental health care, and so we had someone speaking about TMS and ketamine, which TMS is kind of like it's like a magnetic stimulation machine of sorts.
Okay.
And then we had, what did we have? The first one, pelvic floor therapy,
Oh,
which was really powerful. You heard Sydney speak at the
hmm.
conference. She did
Yes.
our first webinar. We have one coming talking about acupuncture. So really, it's just to give people a taste
Yes.
of these different intersecting topics, because perinatal mental health, that topic is so vast
It's so
and
vast.
deep
Yes.
and wide that you could there's so many different angles that you can take in terms of understanding it on a deep level. So
Yes.
that's one way that we try to get some of that education out there every year. And that now that we're a CE provider, we offer CEs with that as well.
Yay. So let them know what our organization is and our website and all that good stuff.
Sure. So we work for Maternal Mental Health Now. And the now is in capital letters because now. But our website is www.maternalmentalhealthnow.org. You can email us for general training questions at info@maternalmentalhealthnow.org. I am separately employed
Yes.
with a group private practice called ARC Counseling and Wellness. So arccounselingandwellness.com. Yes.com. And I have a small practice there. And of course, I specialize in perinatal mental health, but I also have another specialty in highly sensitive people, the
Okay.
HSP trait. So I tend to attract folks who are becoming pregnant and are in HSP. And so I have that specialization in supporting parents who are HSP and kind of navigating the parenting experience as a sensitive, empathic person. And let's see here. What else did you? I think that's it.
Okay.
Our organization and my therapy. Yes, that's it.
Yes. Yes. Well, again, we could talk and talk, I know, and I
Oh
just
yeah.
really am so honored and privileged to not only work with you in this community, but also for you just taking out this time to speak to us on Queenship Quarters. I just really am so grateful for you and so grateful for your spirit, so grateful for your knowledge. And I'm open and just like a sponge, soaking it all up. I just want you to know that as much as I can, while I'm blessed to be in your presence and to be around you. So, well, again, gratitude, my sister Queen, and again to all our listeners and our viewers, as usual. As I end every episode, this is not a trend. Queenship is not a trend. It is your divine essence. You are the essence, the vibrations, and the energy of a queen. So stay tuned. Continue to follow Queenship Quarters.
Ashe.
Ashe, ashe, ashe. And
Mm-hmm.
thank you, Sister Queen Anna. And we really appreciate you and we honor you. And we'll see you guys again on the next episode of Queenship Quarters Podcast. Thank you.
So much gratitude to you, Miss Holly. Thank
Gratitude.
you.
Peace.